My presentation today is on the state of the art of eMTCT. In terms of presentation outline, I'll talk about the evolution of the science and program policy, progress we've made to date, the new global strategy, and how do we move forward. Without intervention, we know that 5 to 45% of pregnant women living with HIV will transmit HIV to their infants. This is knowledge that we've had since 2002. Today, we have 1.3 women living with HIV that are at risk of transmitting HIV to their children during pregnancy, delivery, and breastfeeding period. We know that effective delivery and early delivery of maternal antiretroviral therapy and adequate virus suppression will reduce this risk to less than 1%, the so-called undetectable and infectious. Current WHO recommendations is that maternal HIV diagnosis must immediately be followed up by lifelong ART in all women. This is data just illustrating the risk of HIV transmission mother to child associated with viral load. And if you look at the first two rows, if you compare viral load less than 400 copies with viral load equal or more than 400 copies, the data indicates that we have an increased risk of mother-to-child transmission of 3.5% in formula-fed infants, but it goes up to 7.3% in breastfed infants. And the same is true when we look at viral copies either less than 1,000 and more than 1,000. And this data, the background to this is that the longer the woman is on treatment during pregnancy, the better the antiretroviral regimen she's on, the better suppression that we have, and hence the better transmission risk to the baby. So as the science has evolved, WHO has been at the forefront of translating what we know into guidance that countries have adopted and implemented on the ground. And what I want to illustrate here is that the rich guidance that we've had going back into 2000 and all the way down to 2019. And I think what's different here, if you look at 2001, we were very much focused on providing prophylactic therapy to pregnant women, and no recommendation at that time was therefore when to provide ART to pregnant women. And a lot of the skeptics actually highlighted the fact that we're missing out on providing lifelong treatment to pregnant women. And so where's the mother in the mother-to-child transmission discourse? And moving forward, you can see from 2004 to 2019 that we're now cascading more towards not only looking at the preventive treatment for children, but also looking at ART provision from 2004 at a CD4 count of less than 200, and moving all the way to 2013, where we're looking at option B with a treatment with CD4 of less than 500. And now WHO recommends a treat-all approach for all pregnant women, regardless of CD4. And we've also moved into recommending dolutegravir as the preferred regimen as the first line for pregnant women. So what has this translated to as countries have implemented programs on the ground? So I have in the arrows the changes in guidance, but then I think what's important on this slide is to recognize the enormous progress we've made in expanding treatment access from 1% to 45% between 2000 and 2010, from 45% to about 83% in between 2010 and 2015. Of concern is the stalling in treatment access between 2015 and 2020, and that we missed the target, the global target of 95%, as you can see in the dark bar there in 2020. So then moving forward, so how does this break down this progress that we've seen break down by region, and you can see that in all regions, there's been progress. But then you can also see that at the top end of the progress in the last few years, most of the regions have stalled. And I think what's most important also is to recognize the differential coverage between regions. Some regions are progressing very well, like East and Southern Africa, now at greater than, most women, 95% of them accessing treatment, compared to West and Central Africa, the other epicenter of the epidemic, with only 56% of women accessing. And you can see that that access is also similar for South Asia, Middle East, and North Africa. So we know that early treatment is associated with better virus suppression and also better reduced transmission risk mother to child. This is just data illustrating what has happened over time. As treatment programs for adults have been expanded, you can see in the blue bars now that there's been progression in terms of women that are entering pregnancy already on ART. And in 2020, it was 65% of women globally were entering pregnancy already on ART, which is a very good thing. The breakdown of this proportion of women entering pregnancy already on ART is also variable by region. But then again, you can see in East and Southern Africa that it's about 68%. And when you look at West and Central Africa, it's only 51% of women entering pregnancy already on ART. This schema now looks at what's happening country by country, and this is West Africa. And important to note here that in terms of our benchmark of 95% coverage for 2020, in West Africa, it was only Benin that achieved this target. And you can see there, I've already mentioned the low coverage across the region, which is 56%. When you look at East and Southern Africa, you can see the enormous progress in 9 countries. Coverage is over 95%. And I want to add Eswatini there that is not highlighted in green, but it's at 95%. And then you can see the high coverage in this region across the countries of 95%. So we've made quite a lot of progress, but the response, as you can see, by region and by country is variable. So we have set a benchmark globally of eliminating mother-to-child transmission, and you can see there in the box that we've set very ambitious and bold targets around this. And so to achieve elimination for HIV transmission, we're talking really of a case rate of less than 50 to 100,000 live births, or an MTCT transmission of less than 2% at population level of pregnant women, or less than 5% in breastfeeding populations. And you can see that there's a cascade there, graduating from bronze to silver to gold towards elimination. And the map on the right actually just illustrates where countries are in terms of coverage. And I think the disappointing thing for a lot of us that work in this area is, despite the hard work that countries are doing and the progress that they've made, in Africa, it's only Botswana that has been certified by WHO to be on the path to elimination last year. But you can see the other countries on this schema that have been certified by WHO. So the issue for us is, what else do we need to do to get countries in Africa up to speed to getting to the status of elimination? I just wanted to point out here that as we think about this, it's really extremely important to understand that we're actually talking about chronic care of pregnant women. So seeing them through pregnancy, through delivery, and then through the breastfeeding period. And this slide actually illustrates part of the problem that we have, that despite the high coverage in some of these countries, we still have a lot of countries that have very high mother-to-child transmission rates. 13 of the 21 countries prioritized in Africa have a mother-to-child transmission rate of over 10%, and we're trying to get these countries down to less than 5%, less than 2%. And also to note that half of this transmission, that over 10% transmission, is actually happening during breastfeeding. So there's a real question as to what are we doing to support mothers better during the longitudinal follow-up, especially when they are breastfeeding. A lot of these mothers are probably dropping out of care. A lot of these mothers that were previously negative might actually be getting infected during breastfeeding. So extremely important for us to recognize that fact. The other thing that we need to recognize is also how COVID is also disrupting services, not only for PMTCT, but more importantly, antenatal care and follow through of antenatal care. And this is just a slide that shows the effect that we are seeing over time on HIV testing in pregnant women. And you can see that in the early months of the epidemic in 2020, there were dips in testing rates, but there was a rebound. But you can see that in most of the countries, also that rebound has not come back to where we were before COVID. So it's very important for us to also look at what adaptations we need to make our programs more resilient to some of these shocks, including COVID. So moving forward then, we do have a new global strategy on AIDS 2021 to 2026 that really gives us renewed hope and helps us to rethink what is it we're going to do. And of importance on this, I know it's a crowded slide, is to recognize that we are still trying to get 95% of mothers on treatment. We're also trying to look at how we can effectively integrate some of these services so that we can have value addition in terms of impact. The other target is that less than 10% target that looks at countries that have punitive laws and policies, countries that locations that are still experiencing a lot of stigma and discrimination, as well as gender inequality and violence. And we want to get those indicators down to less than 10%. So again, ambitious, bold targets and requiring program redesign. So then how do we move forward? I have a few slides on this, just to mention that in 2020, we did put out a review, Accelerating Progress Towards Eliminating Mother-to-Child Transmission, where a lot of the things that I'm going to talk to now is highlighted in that publication. But also we do have publications, UNICEF publications that look at how are we going to get to the last mile of PMTCT. And we also have a technical brief that is looking at measurement of mother-to-child transmission so that countries can do this themselves to really understand where they are in mother-to-child transmission rates, what data they need to feed into that analysis, but then moving that forward to what are we going to do moving towards the last mile. So this is a schema that probably is familiar to all of you, but starts to look at how we can better utilize the data that we have and using the spectrum models that we've been using for epidemic projection, trying to understand where are the infections for mother-to-child transmission coming from. And you can see here, looking at the global data in 2020 or 2019, that at that point, we understood that 27% of the infections were linked to pregnant women not accessing ART. And then 27% were due to poor integration of HIV prevention in prenatal and postnatal services, resulting in very high incident infections in previously negative women. And then 24% was due to poor retention in care with poor adherence and women dropping out of treatment and care. So you can see that it's almost equivalent across, across these three domains. And so what does this mean when we look at the regional context? So this is the same slide now looking at what is happening in Eastern Southern Africa and what is happening in Western Central Africa compared to the whole Sub-Saharan Africa. And what I want to highlight here is that you can see here that when you look at Eastern and Southern Africa, you see in the deep orange that most of the infections are happening because women were infected during breastfeeding. And then when you look, in East and Southern Africa, again, you see in the yellow that we still have women that are not passing on infection to their babies because they were not on ART. But when you look at West and Central Africa, the yellow really is very striking, that the majority of women in West and Central Africa are passing on infection because they had no treatment, either during breastfeeding or during pregnancy. So we've been trying to use this metrics to look at what does it mean for the different countries. Now, this is a country, this is data that I got from Angela Mushavi in Zimbabwe, where Zimbabwe, in terms of PMTCT population ART coverage, it's at 88%. But when you look at women that are within their captive that are coming to ANC, that country's coverage is about 96%. And this cascade just tells you out of the 502,000 plus women expected pregnancies in Zimbabwe, how many are actually being tested and who know their status. And you can see that their testing rate is about 96% of the women that are coming within their captive. The second bar there is just women that are coming, the expected pregnancies that are coming for ANC, which is very high, 92%. And then 96% of the women that are coming to ANC are tested. And that brings them to 54,000 in the fourth bar, women that are living with HIV that need ART. And you can see there that their population coverage in terms of women, pregnant women, is about 87%. So they've done very well in advancing treatment to pregnant women. But what does it mean when we apply the stack bar analysis? And again, here, this is Zimbabwe looking at, and you can see in the deep red, when you look at the 500,000 plus infections that are happening today in Zimbabwe, you can see that in the red is women that did not actually receive antiretroviral therapy, and their transmission risk in Zimbabwe is 8.7. So it's not less than 5%. So this matrix is extremely important for us to try and understand what's going on and have better allocation of resources to those areas that will actually help us in continuing to draw down infections. So this is, again, Zimbabwe now applying the knowledge that they have for the 5,113 infections happening in Zimbabwe. What happens if all women were retained on care? They would save an additional 1,406 infections. And if all positive pregnant and lactating women were provided ART, they would save 1,844 new infections. And if they provided PrEP to negative women in that program, they'll save an additional 927 new infections. So with this type of analysis, you can see where Zimbabwe would need to weight its focus in terms of moving more towards elimination. I think what this data also tells us is that for a long time, we've been pushing that coverage data, trying to get countries to 95% coverage of maternal ART. What this data is telling us is that without good quality programs that are focused on retention in care, without good quality programs that also address new infections in pregnancy, we're not going to get to elimination of mother-to-child transmission. So with that knowledge, UNICEF, UNAIDS, and WHO are coming together with a new global initiative to eliminate vertical transmission of HIV mother to child, but also to end AIDS in children, trying to invigorate a new agenda that can help countries redesign their programs around the elements that I've been talking about. So we're building on what we've learned before with the global plan to eliminate mother-to-child transmission, which was between 2010 and 2015. And you can see from what I said before that this plan really helped us galvanize treatment expansion in pregnant women. There was a lot of political will and global efforts to support that. And then we moved to another algorithm, which was called the Start Free, Stay Free, Age Free in 2016. That was again looking at how do we bring all these things together. And what was different in this is that we also embraced treatment access for children, but also embraced prevention of HIV in adolescent girls and young women. But moving forward, what will be different with the new alliance to end vertical transmission and end pediatric AIDS? There are 3 bullets here. We really want this to be country-owned, community-driven, so empowering countries to be able to find their own solutions to the elements that I've talked about, and also supporting them to make sure that they're innovative and they can be flexible in introducing new tools that will get them there, and then to have a comprehensive indicator framework to help us monitor what's going to happen. And so just finally to say that there are 3 pillars to this alliance, and I'm not going to talk about early testing and optimized treatment for infants because that's not my job today, but I'm going to talk to pillar 2 and pillar 3. So pillar 2 is about closing the treatment gap for pregnant women and breastfeeding women living with HIV, but not just looking at that, also optimizing retention in care. And there are elements on this slide of what we need to do, including making sure that for countries with low prevalence, we're looking at this in an integrated way that starts to address elimination of syphilis transmission, but also elimination of hepatitis B where it makes sense. But the more critical point also is having differentiated services that are tailored to the specific needs for that program. And then pillar 3 is also is about preventing new infections among pregnant women. And in here is really being intentional and making sure that programs are doing that partner testing to make sure that treatment as prevention to the positive male partners with negative pregnant women is part of the program, or the linkages are made with a broader treatment program, but also retesting HIV negative women during pregnancy, but also during the breastfeeding period. And additionally, making sure that the PMTCT program is also integrating innovative preventive technologies like PrEP for pregnant women at high risk of infection. So we have oral PrEP, and now with the long-acting injectable PrEP, this should be possible. Partner engagement to make sure that they are also accessing services in an integrated way within the MCH program. So those are the 3 pillars. I've spoken to 2 of them, and finally, I just want to acknowledge the team at UNICEF who helped me put these slides together, and also WHO, Meg Doherty, the director of the AIDS program at WHO, that is a good partner of UNICEF in a lot of the work that we do. Mary Mayhe for the data that I've presented, and Angela Mushavi for the Zimbabwe example. And with that, thank you very much.